Today, women in their teens and early 20s are being infected with HIV at the fastest rate. Nationally, HIV is now one of the leading causes of death for women in their 20s and 30s. Although women clearly share some of the same issues with men when confronting HIV and AIDS, many issues are unique to women only. We as caregivers have a responsibility to both understand and appreciate these issues and learn ways to incorporate them into our counseling techniques. Speaking on the topic of women and HIV is Ms. Sue Gallego. For the past 4.5 years, Sue has been the Director of Client Services for AIDS Services of Austin, a community-based AIDS service organization. In this capacity, she is responsible for supervising a number of services including case management, buddy helper support, nutrition, and housing programs. Prior to this, Sue was a social worker with the Austin City Health Department and worked with pregnant drug users. She is a national trainer for the Center for Substance Abuse Treatment and a member of the HIV Task Force for the National Association of Social Workers.
Thank you, Jack. The needs of women have always represented a unique challenge to healthcare and service provision systems. Challenge is not well met traditionally and currently exacerbated by HIV. It is also clear that women have different characteristics, problems, and service needs than men. We, as counselors, have a responsibility to respond compassionately to women's concerns and create specific intervention strategies that will help change the course of HIV/AIDS and its effect on women. We're running out of time. Today, the fastest growing group of people with HIV/AIDS is women. From 1986 to 1990, HIV infection in women in the U.S. increased more than 600%. This increase rate of infection was 2.5 times faster for women than for men. And as of September 1993, over 43,000 women have died of AIDS. It is also important to remember that because of the long incubation period of AIDS, current AIDS cases represent HIV transmission from 5 to 10 years ago. By the year 2000, it is estimated that the number of women infected with HIV in the U.S. will equal the number of men with HIV infection. According to the Global AIDS Policy Coalition of Harvard University, by the year 2000, there will be 60 million HIV-infected women worldwide. Examining issues around HIV in women means having to talk about some uncomfortable subjects like women's bodies, excretions, sex, what we know and do not know about what women's partners have been doing with their bodies, and ultimately examining socioeconomic and political issues that link isms like racism, sexism, classism, ageism, and heterosexism to the tremendous lack of funding and commitment to addressing the specific needs of women in our society. Throughout the HIV epidemic, many different groups have suffered from these isms and been made to feel invisible and powerless. In highlighting women today, a very broad and diverse group, my intent is to share what I've learned from my mentors, colleagues, and the women with whom I've worked. I also want to honor all the battles that people with HIV have fought while I focus on women. In reality, as long as we allow any one person or group to remain invisible in this epidemic, we are all powerless and no progress will be made. Young women have the weakest voice and the least power, yet their incidence of HIV infection continues to increase, making them a significant part of this epidemic. They are only acknowledged when we examine statistics telling us that 85% of women with AIDS are young adults of childbearing age, that is, 13 to 39 years old. Adolescents have become sexually active, and the paternalistic withholding of information from young women poses a threat to their health and survival. For the most part, women in the AIDS epidemic have been described and considered mainly as vectors of transmission, infectors of unsuspecting men and innocent children. This early view of HIV-infected women prevented them from being viewed as individuals, themselves infected and victims of transmission. Every woman, whether or not she is a mother and regardless of the mode of transmission, deserves equal access to the best health care and treatment available. Today, the face of AIDS is getting younger, darker, and more feminine. For women, the risk of HIV has increased steadily around the world. Women's general lack of control over their bodies and their lives, partially due to the economic structures, has served to encourage high-risk behaviors by women seeking to survive in systems with limited opportunities. Those women with the least social power, poor women of color, consequently are at the greatest risk. I can remember one of the first AIDS 101 classes I was mandated to attend as a city health department social worker about 9 years ago, and learning at that time that 80% or more of the babies born to HIV-infected mothers would themselves have AIDS and die before their second birthdays. We were even told that pregnancy was a cofactor, exacerbating HIV. Current research suggests that pregnancy does not accelerate HIV disease, and at the present time, no one knows how to predict which mothers will transmit the virus to their babies. Generally, mothers recently infected with HIV and those in the later stages of AIDS have the highest transmission rates. It is also important to note that some of us also perpetuate the myths about women and HIV by our own denial and biases that are often brought about by the societal messages that most women, the good girls, those who stay with one partner and do not use drugs and run around, aren't really at risk, as opposed to the bad girls, those who have multiple partners and who are sex workers or addicts. Let's talk about the increasing number of women who cannot identify themselves as part of a risk group. Often these are women who do not fit into obvious high-risk categories, like injection drug users and sex workers. They point out that they do not need to change their behaviors since they are in monogamous relationships. These are the same women who report through popular women's magazines that 30 to 50% of their marriages experienced infidelity and affairs. In the U.S., the proportion of women who have contracted AIDS by heterosexual transmission has increased from 11% in 1984 to 37% in September of 1993. Just as a comparison, 3% of men were infected through heterosexual transmission in that same period. Worldwide, the highest rate of transmission is by male-female intercourse as opposed to male-to-male sexual activity. It is also important to note that women are at the greater risk than men for acquiring HIV through heterosexual contact because, 1, a greater proportion of men are infected, increasing the likelihood that women will have an infected sex partner, and 2, the virus transmission from man to woman is more efficient than from woman to man. This is the biology of the double standard. We must also keep talking about HIV-infected women who are incarcerated, who live in remote rural communities, who are hemophiliacs, who are lesbians and bisexuals. In many parts of the U.S., lesbian health care workers were the first to respond to this epidemic and played a crucial role in the development of early AIDS service organizations. And today, they are some of the main movers and shakers in AIDS policy and care. But they too have often forgotten to care for themselves and examine their risk for HIV. Lesbian and bisexual women have been ignored, partially because of sexism, a general refusal to acknowledge that women can participate in a wide variety of sexual behaviors. Let's now examine some of the barriers to health care that create unique challenges to women and providers. Clearly, differences in hormones, genetics, sex roles, social conditions, and socioeconomic factors are all likely to influence virus exposure and the disease process itself. The majority of women's health care in the U.S. has traditionally been centered around maternal health. For some of us, it is the only time we get health care, and it's really not for us, it's for the baby. This is also where the majority of women have found out they are HIV infected. It has been either during pregnancy or when a newborn or young child has become ill for unknown reasons that an HIV test was done and the family was informed about the child's HIV status. For many of these women, the diagnosis came abruptly, and it meant having to deal simultaneously with the knowledge of their child's illness, their partner's HIV status, and their own. Many of us know women that we've worked with who have died of AIDS, women who were never diagnosed with AIDS, women who were unable to work, provide for their families for up to 2.5 years and couldn't get any disability benefits because they didn't quite fit into the AIDS-disabled categories for Social Security or the AIDS-defining illnesses of CDC, and had no money and no link to physicians who could document enough illness to qualify for benefits. It took until January of 1993 for some good news and changes to take place with CDC guidelines. These new guidelines added one female-specific disease manifestation to the CDC's case definition of AIDS, cervical carcinoma. Many people in the medical community believe that cervical dysplasia, which occurs prior to an actual cancer diagnosis, should have been included in the new case definition. Also changed were CD4 counts, which were expanded to include people with less than 200 T cells, bacterial pneumonia, which must occur twice in a 12-month period to be counted, and TB were also added. These changes are steps forward. more inclusive of women and people with injection drug use histories, and will more accurately count cases. As we move on to the psychological issues, it is important to note that the key issue that sets women apart is their role of caregiver. That is, the multiplicity of roles tied to taking care of others, their parents, children, partners, and friends. This, along with the socioeconomic status of women in general, exacerbates some of the issues of denial and fear of isolation which most people with HIV face. Many HIV-infected women continue to be attached to the traditional female roles of caregivers. Their fears and concerns revolve around their children and their partners. They have been socialized to not focus on themselves or articulate their own emotional or physical needs. This other-oriented, outer-focused perspective is related to selective denial. An example being the HIV-infected woman who makes sure her child and partner get treated at the clinic but denies her own health care needs by missing her appointments. Sometimes these women, if they are with a non-HIV-infected partner, express a great deal of concern about being abandoned for a healthy or healthier woman. The role of caregiver also increases the likelihood that women will keep their HIV infection secret longer, hoping to protect their children, families, and partners from societal prejudices and discrimination. Often the role as pillar of the home directs her to keep home and family together, even at the risk of her own health and life. Another challenge she may face as caregiver is related to role reversal, a common occurrence for women dealing with terminal illness. When a woman becomes sick, a partner, child, or other family member, often another woman, is called upon to care for and nurture that woman who has been the primary caregiver for years. This clearly disrupts the family's relationships and can perpetuate dysfunctional roles that continue for years, even after the woman has died. The loss of her caregiver role, along with all the other losses related to HIV, such as of body image, income, and control, makes it essential for providers to examine these concerns thoroughly. It is important to acknowledge another strength of the caregiver role. Many HIV-infected mothers are engaged with the world through their young child's life, which is full of energy and enthusiasm. Through caring for children, women are unavoidably swept up in living. On the other hand, children also add stress to the already busy, sometimes chaotic lives of their mothers. Guilt, grief, and exhaustion can envelop the lives of these women. Counselors need to explore the women's feelings of guilt and losses of control and then work to enhance support systems and access to care which can minimize the mother's burden. Obviously, the HIV-infected woman's caregiver roles extend to the issues of childbearing. Many of us in the field have some very strong feelings about these issues, and it is a continual challenge for us to put aside our own agendas and work with our client's agenda. It's not unusual for people with a terminal illness to focus on leaving behind some creation, a part of themselves. For many women, a child symbolizes this. Having a child for many women is a desperate attempt to combat death and leave a legacy. The birth of a child may also serve as a bond to a continuing relationship with a partner. Counselors will need to explore these feelings of deprivation and lack of control that may be tied to childbearing decisions. The loss tied to this is often one of the many shattered dreams that women with HIV experience. We need to give information and respect the woman's right to make her own decision. If we can come from a place of respecting our clients and their dignity and put our judgments aside along with the latest statistics and information about financial, medical, and emotional costs of HIV and pregnancy, we stand a much better chance of really helping people. Many women who are injection drug users may appear healthier during pregnancy because they've cut down or stopped using drugs. The caretaker role also sets women up for increased stigmatization with this disease. The mindset for many people is, if she had been a good caregiver, she would never have gotten this disease. HIV can then symbolize her failure as a caregiver and can essentially limit the support and sympathy she receives. This is tied directly to the caregiver role, the fear of losing a partner, a child, or family approval. This is a particularly powerful issue since it inhibits women from trusting friends and providers and going to support groups or obtaining needed services. The negative judgments and stigma they sometimes experience from the community, their families, and providers can create barriers to the utilization of services. For many, it is past experiences with legal systems, state programs threatening to take away children, or fear of la migra, immigration picking up undocumented people on their way to their doctor's offices, that prevents them from participating in services and trusting the systems and providers. All providers of services to women need to hold women in high regard and treat them with respect. This will increase personal self-esteem and ultimately enhance self-care. HIV infection damages one's dignity. Our efforts with clients need to begin from a place that enhances dignity. This means hiring people who have a genuine respect for women and possibly doing sensitivity training with staff to encourage the development of women-centered approaches which treat sex workers, junior leaguers, women with addictions, pregnant teens, mothers, bisexuals, lesbians, and all people in jail equally and with respect. Emphasizing relationship-based counseling and role modeling is essential to working more successfully with HIV-infected women. While there are tremendous benefits to the provision of services by diverse interdisciplinary teams, the key point person, the provider who is the main contact for the female client, in my opinion, must be a woman, trained and sensitive to women's issues. This concept is not meant to diminish the value and importance of male providers or the significance of the role modeling they provide, but rather to acknowledge the power of women connecting with women. Starting where the client is probably one of the oldest, most solid social work premises and is extremely invaluable in working with HIV-infected women. Respect them for who they are and start where they are. Sometimes this means putting aside our medical or social work titles completely. I've been told by more than one of my clients that if you're a social worker, you must be from child welfare and trying to take away my kids. So titles aside, psychosocial, medical assessment paperwork aside, we may just begin by talking about the price of bananas, the soaps, stories, or men. This chatting is really part of the business and can demonstrate your genuine interest in her and your willingness to be a partner in her fight against AIDS. This is another way of connecting with a woman, and it will and should extend to other members of her family. In some cultures, this is a way of showing respect for the client. To begin abruptly with a status check on her Social Security disability or food stamps is thought to be disrespectful. Once the counselor moves on to other items on the agenda, such as the status of Social Security disability, then I believe that it is important for the client to observe the counselor in an advocacy role. This ties into earlier statements about role modeling. That is, as the counselor calls the Social Security office or the pharmacy to advocate for services for the woman, the client is observing, building her confidence and trust in the counselor, and learning. Being on a client's turf is often empowering for her and allows her to have more control and gives the counselor a wealth of ideas for providing support. When working with indigent women, it is also important to keep in mind that often tangible support has the greatest value and helps in building stronger, faster bonds of trust. This may mean that the initial sessions with a woman center around her basic needs and assisting her with those needs, such as helping a mother get a crib for a child rather than discussing her feelings about her recent hospitalization for PCP. This begins to build a base of trust and a belief in the client that working with the counselor can make a difference. With these kinds of actions and time, the client will be more open to talking about her other needs, feelings, and fears. An additional thought for counselors is to consider expanding basic education and training for female clients around what they need to know about their basic rights. This includes legal clinics and training around the guidelines and ramifications of the Americans with Disabilities Act. Finally, a simple suggestion that carries a big message. Wherever there are condoms, KY jelly, and non-oxynol 9 made available at an agency, also consider having dental dams for HIV prevention and spermicides and sponges for pregnancy prevention, equally available and clearly represented. As others have pointed out before, all of us together must fight to not allow any segment, group, or subgroup of our society to remain invisible in this epidemic, and we must join forces to create partnerships. It is what many of us did in the early days of HIV, and it is what we must continue to do to save the lives of women. We must forge true alliances based on mutual respect and the equitable sharing of the burdens created by this epidemic. This includes sharing the responsibilities and the joys. Thank you.
Sue, thank you for that presentation. I think you really covered a lot of the issues that are affecting women with HIV in an extremely both comprehensive and I think very, very practical way. I think you gave some really important suggestions. I'd like to build on a couple of the issues you talked about, and one I think is of extreme interest, and I know it's particularly of interest to you, is the issue of both access as well as utilization of services, both medical services as well as clinical trials for women, and any thoughts on other strategies that counselors might be able to use to move that agenda forward?
Well, I think another role for the counselor certainly is to advocate, and advocate with women around becoming involved in clinical trials and research. Many of our communities have research already going on in clinical trials, and it's a matter of our relationship building with that particular woman and talking to her about helping her get involved in the trials. And I think another level of advocacy is certainly working with all the systems, all the agencies around having child care available. And by child care available, I don't necessarily mean somebody who can watch the kids while she's in the doctor's office. I mean, you know, separate space or separate area with toys, and perhaps a paraprofessional working in there to help with the kids and so forth, and really opening up systems to be utilized by women who have children, creating transportation services, and perhaps some more incentive type programs for women who participate in drug trials. You know, grocery store vouchers and so forth are other ways. And while I realize that counselors are very busy out there working one-on-one, sometimes their advocacy with their staff and management and around them can also create some of these changes.
Well, those are some very similar issues that I think the drug abuse treatment setting has experienced for many years, particularly because it was based on a very male model, and I think that arena is struggling with how, in fact, to be more accessible to women. I'm wondering if people have had other experiences with that particular issue around access and utilization of such services.
I think one of the things we're still locked into is our early assumptions about the faces of HIV/AIDS in terms of who has access and who does not have access to services. And so we have not totally gotten past the era of AIDS being considered GRID, gay-related immunodeficiency, and where we perceived it to be male, perceived it to be gay male, and many cities across the country are only now beginning to look at non-gay community, only now beginning to look at the fact that women are infected, and still many service providers and persons in the community still do not know women who are infected, and I think a lot of that is because women who are infected still are very silent for a number of very valid reasons that you gave in that particular instance. So I think that's a part of the stigma that we're dealing with, that when clinical trials come about in certain cities or services are set up, it's also true of treatment programs. Very difficult to find drug treatment programs that women can get into because they're very male dominated, or looking at housings for persons with AIDS. It's very limited number of places that women can go, and a lot of it I think is getting through the original erroneous assumptions about what the faces of this virus look like.
I want to pick up on something else that you said, Sue, and that is the issue that a lot of women find out they have AIDS at the time of a terrible disease, and it could be a lot better for them if they could learn that a lot easier. And I think it's really another place that counselors can advocate is with the medical systems to have medical care providers think about HIV much earlier so that all women are apprised of potential risk. It really is true. The data, we've collected data on this, that most women are at risk for HIV by virtue of their partner's behavior. And they don't think of themselves at risk. And therefore it really is important for the counselors to work with medical providers to bring up issues of potential risk much earlier in the process so that they can have their disease identified much sooner.
Right, that's a very good point. When they're coming in perhaps with yeast infections or coming in and talking about what's going on at home, we need to be clicking as counselors, oh, well, that's perhaps leads to high-risk behaviors on the part of that partner. Maybe I need to talk to her about getting hooked up in the clinic. Maybe I can talk to her physician more. Absolutely.
I think that point cannot be emphasized enough, because I think so many poor women or women who are from communities of color may have a history of real negative experiences with healthcare systems. And there may be, you know, all of the multiple concerns of a caregiver and of a woman, so that her own health, as we've said before, is one of the last things that she goes to. It's more important to put food on the table. It's more important to have shelter. It's more important to take care of those kids or whatever. Health is not that much of a priority, so that whenever a woman enters into our venue, you know, whether that's for family violence or shelter or whatever, it's really important to be clicking off those risk factors and looking at where we can move in and educate and work with her around changing behavior.
I think one of the things that your presentation points out is we focus a lot around doing needs assessment and risk assessment with the individual that we're working with. And I don't think we place enough emphasis or have trained ourselves to help the person that we're working with to also do a needs assessment of their partners and the relationships in which they're in. We may ask a few questions, but actually then getting them to do an assessment of their partner is a key part that we may have missed the boat and probably need to go back and re-examine how to teach women to do that, how to teach youth to do that, how to teach addicts to do it. A number of clients that we're working with, like, okay, we spent time assessing your risk and your behavior. Let us now look at how we can assess those that you're in relationship with.
I think the issue is that we get different things from different people, and I can really understand a situation where a woman working with a woman gets a lot of power. I mean, they're bonding around very similar issues and very similar experiences as persons of color with persons of color, as gay men with gay men, as lesbians with lesbians. There's power in that, but there are also situations that are perhaps one would be reluctant to talk about with another person who's very similar to yourself, and there may be lessons learned across as well. And I guess it's sort of figuring out how to best mix and match. It's no easy task, and it's partially intuitive.
It actually raises some interesting points around socioeconomic status, in that for somebody who may be able to easily afford a therapist, a counselor, their own provider, they're clearly in a more empowered position to select the gender of their provider, whereas somebody going to a more publicly funded program, it may be selected for them. And I'm wondering if there's some issues there that will need to be considered at the same time, the opportunity for a client to, in fact, for that to be explored in terms of who are they most comfortable working with.
Dr. Robert Remian is a psychologist in New York City. He has a private practice in which he works with many HIV-positive and AIDS patients and their partners and family members. He is a senior faculty member for the American Psychological Association HIV training program. Bob has been a volunteer for the Gay Men's Health Crisis, and he is also a research psychologist at the HIV Center for Clinical and Behavioral Studies at Columbia University. He is currently conducting research on long-term survivors of HIV and AIDS, substance abuse and HIV illness, the psychoimmunology of HIV illness progression, and the coping strategies of serodiscordant couples. Bob.
Thank you, Tom. I would like to begin this presentation by acknowledging my friend and former colleague, Dr. Leon McCusick. Readers of the HIV Frontline know that we lost Leon to AIDS last August. I'd like to acknowledge his contribution to my work in thinking about HIV and for many of the ideas I will be sharing with you today. I wish to thank him for his commitment, guidance, and inspiration for me in doing this work. He is greatly missed by all of us. I'd also like to acknowledge the contributions of my colleagues from the Office on AIDS at the American Psychological Association. There are three major players in the psychological fight against HIV disease. First, there is the person living with HIV or AIDS, whom I will refer to as the patient or client. Second, there is the primary health care provider, typically a physician or perhaps a nurse or other allied health professional. Last, but certainly not least, is the counselor or therapist. I am here today to focus on the role of the counselor when working with clients across the HIV spectrum. And this all takes place within a social context, or a social support system. People living with HIV are living longer. This is important for frontliners because it means there is more time to intervene, medically and psychologically. There is more that can be done behaviorally and socially during the course of disease to maintain health and quality of life. In addition to long-term AIDS survivors, there are many people today living more than 13 years with known HIV infection and who have remained asymptomatic, that is, whose infections have not progressed to AIDS. The individual disease course varies widely. It's possible that some will never progress to AIDS. Nevertheless, while there is treatment, there is no cure. Most medical experts agree that HIV-infected people will run the course of HIV disease, albeit at varying rates, and will eventually die of one of the AIDS-defining illnesses. In addition to long-term AIDS survivors, there are many people today living more than 13 years with known HIV infection and who have remained asymptomatic, that is, whose infections have not progressed to AIDS. The individual disease course varies widely. It's possible that some will never progress to AIDS. Nevertheless, while there is treatment, there is no cure. Most medical experts agree that HIV-infected people will run the course of HIV disease, albeit at varying rates, and will eventually die of one of the AIDS-defining illnesses. The big question then on the mind of the HIV-infected person are as follows. How long will that take for me? What can I do behaviorally, or what treatment can I take that will influence how long I live? What reasonable expectations can I have about the quality of my life in the meantime? And how can I maintain hope in the context of such overwhelming uncertainty? Time, in both quantity and quality, becomes a very precious commodity, a powerful variable when we discuss HIV disease. In considering the person infected with HIV from the counselor's perspective, it is helpful to start out with the model that Leon McCusick has provided us, as shown here. This graphic depicts the key stages of illness course. Each stage has its own psychological resources and challenges, usually prompted by a medical event, but each also moves us along in our development and tests our ability to cope. As sophistication about HIV treatment increases, we will be able to extend greatly the length of this whole cycle. I view this model as a beginning framework for us to think about some of the psychological challenges inherent in this illness. It is not comprehensive, but allows us to add additional psychological resources and challenges. Also, it's important to note that the psychological resources and challenges we talk about are not unique to specific illness stages as depicted in the model, but rather can occur throughout the illness. This model is, of course, an ideal, a theoretical mapping. In the real world, clients typically come to us in crisis, which may occur in any stage of HIV infection. We thus may not have the opportunity to prepare the client for certain events and psychological challenges. Events are not always as predictable as the model might suggest. Nevertheless, there are many issues and challenges that we as counselors do encounter in clients at all stages of the disease. In this graphic, you can see how psychosocial issues correspond with medical issues across the spectrum of HIV disease. Let's talk about some of them now, and let's focus on working with our clients once they are known to be infected. We know that the client often experiences a positive test result as a death sentence. Depression, anxiety, guilt, shame, loss of libido, and fears associated with real and imagined rejection, loss of income, and isolation are common. Anger often predominates as well. Anger may be directed at the people who are possible sources of infection, at oneself, and at the perceived failure of the medical and political establishment to respond adequately to the epidemic. Counseling, both before and after the test for HIV is performed, will significantly reduce distress associated with receiving positive test results. Several studies have failed to find increased psychopathology in HIV-infected individuals over time as compared to their counterparts with negative serostatus. As counselors, we need to validate the range of feelings that our clients may experience and provide them with the right kind of support. The client's anxiety is best managed by focusing on setting short-term goals and problem solving. Counselors should help the client focus on the controllable aspects while acknowledging the frustration and feelings of loss over uncontrollable events and circumstances.
You think you worry about it?
I worry about it.
And worry about AIDS and worry about, is it dying
Yeah.
specifically?
Examples of goal-directed activities that can be focused on include information gathering about the disease and various treatments, lifestyle changes that help the client feel better, such as dietary changes, cessation of alcohol and drug use, adequate and regular sleep, and exercise routines. The best support person is someone close, trustworthy, and non-judgmental, someone with whom the client can talk about anything he or she may be thinking or feeling. This may be a close friend, a family member, a lover, or perhaps the counselor. Clients should establish a good relationship with a doctor or clinic if they don't have one, or evaluate the relationship if one already exists. Let's now turn to clients' disclosure of HIV status. We know this is an important issue for many of our clients, and one that typically comes up in the course of our work. We need to encourage openness and honesty between our clients and their sex and needle-sharing partners, and we need to be able to discuss issues of safer and less safe behaviors in a non-judgmental manner. We need to openly acknowledge the difficulty in both initiating and maintaining certain behavior changes. We also should engage in discussions about who else they should inform, as well as how and when to inform them of their HIV status. This can be a highly emotionally charged topic. Some clients react to news of their seropositive status by withdrawing and isolating themselves, refusing to tell anyone, while others respond in a rather histrionic way and have the impulse to tell the world. Neither extreme response is adaptive. We need to discourage withdrawal and isolation. It's also helpful to prevent people from acting on impulse when it comes to disclosure. We must recognize that some disclosures can have very negative consequences for our clients, whether it be the risk of abuse from the boyfriend, rejection from the family because of homosexuality or substance use, or loss of insurance or employment. For some clients, having a disease that may kill them in several years poses relatively little threat compared to the daily risk of staying alive on the street. For many others, however, confronting the possibility of death due to HIV leads to a serious consideration of existential questions. For example, what is the purpose of my life, and how do I derive meaning from the life that I have left? Clients may see themselves as going from career people to relationship people, from political inaction to action, from drug abusers to people in recovery, from wellness to illness, and from bright futures to no futures. Clients normally pass through all the stages of grief as they mourn the loss of the self that they used to be. As counselors, we need to evaluate psychiatric status. While transit distress is common, clinical depression or anxiety disorders are not the norm for people living with HIV, and treatments are available, including the use of psychopharmacology, even in patients with severe immune suppression. Since some of the symptoms of mood disorders are also common in HIV infection, such as lethargy and sleep and appetite disturbances, it may be important to refer your client to someone with diagnostic expertise in this area. But do not hesitate to refer for evaluation. With everything else our clients are coping with, a psychiatric disorder that is treatable should not be added to the list. We also need to deal effectively with our clients' suicidal ideation. Standards of practice apply here, and a therapist or counselor is often obliged to assess suicidality and respond to it as they would with any other client. However, let's be clear about acute suicidality versus having a plan to kill oneself when certain medical developments occur, such as blindness, paralysis, disfigurement, or chronic pain. The former being more rare and the latter quite common. The topic of suicide must not simply be a red flag for counselors whose anxiety about death stimulates the adoption of the crisis intervention suicide watch mode. That is, we must recognize that serious consideration of suicide often provides clients with a sense of ultimate control that leads to a reduction in distress, a calming return to emotional equilibrium, and the energy and motivation to take up the business of life again, at least for the time being. Let's now return to the McCusick model, focusing for a moment on stage 3, beginning and sustaining treatment. Both client and physician must note any changes in overall status, side effects of medication, and early signs and symptoms of secondary illnesses, so that problems can be treated quickly before complications occur. Clients must also meet their resistance and fears about taking medication. With HIV care, aggressive medical treatment is important for healthy survival and quality of life. Timely use of prophylaxis against opportunistic infections is also crucial. I would add honesty versus denial to the list of resources and challenges for this stage. Some use of denial as a coping strategy can be beneficial to people living with HIV. The fact is that the course of HIV disease is unpredictable. It's important for those with HIV disease to imagine a long-term future of good health with much to look forward to and to maintain the possibility of extended survival, where one dies of an unrelated illness much later in life. Some would call this denial. I call it maintaining hope. Denial is bad, however, when it prevents the client from attending to real symptoms and acute events that require medical attention. That's why honesty with oneself and with one's healthcare provider is germane to aggressive and timely medical management of this disease. We as counselors can address the issue in a supportive manner. We can talk about the desire to forget or just not think about it for a while also pushing our clients to confront the realities of this disease in very concrete and practical terms. For many clients, the concept of developing relationships with medical providers and becoming an active member of the medical team is a foreign one. Some physicians who are unaccustomed to patient assertiveness in treatment decisions may be resistant or resentful of their patients' desire for participation. Therapists often can be helpful in assisting clients to assert themselves more effectively or to find physicians who are more willing to collaborate with their patients. Let's look at stage 4 of the model, hospitalization. I prefer to view this as the time that the patient is first sick with a significant HIV-related illness. For clients who were previously asymptomatic, the emergence of symptoms can be terrifying because they symbolize the progression of the disease or the beginning of the end. Panic reactions may be common. Because symptoms can also symbolize failure in clients who have been particularly dedicated to self-empowerment and regimens designed to promote health, new symptoms can produce feelings of depression, self-reproach, and guilt. Other clients minimize the significance of new symptoms and avoid treatment or may completely deny the presence of symptoms. When possible, the counselor's advocacy and active consultation with the medical team can do much to empower the client and foster a sense of control. Continuing to maintain hope in the context of illness progression and often grim news from the media regarding the chance for a cure is indeed a great psychological challenge for our clients and for us. This becomes an even tougher challenge in the context of multiple illnesses and chronic impairment in health. Hope is an extremely important emotion at all stages, but especially during hospitalization, when it is most likely to be diminished. For many, hospitalization can signify progression from asymptomatic HIV or ARC to the diagnosis of AIDS. Clients must be reminded that much life remains after a diagnosis of AIDS. For some clients, it is the second opportunistic infection that is truly devastating. Often there is complete physical recovery after a first illness, and the person can return to what feels like a normal life. Getting sick again, however, is a potent reminder of disease progression. Counselors need to deal with the issue of client follow-up when they enter the hospital or are homebound with illness. You may have differing policies on whether you will visit the client or make phone calls. The best advice I can give is that you try to be clear with yourself and your clients what your boundaries and limits are, but do not avoid the issue. You may need to be more flexible with your HIV clients than you might otherwise be. Close follow-up in times of acute illness can be extremely meaningful to the client, reinforcing the bonds in the therapeutic relationship. Progressive impairment and concomitant increased dependence on others are often significant sources of distress in individuals at later stages of HIV infection. Counselors can be instrumental in preserving clients' sense of purpose and self-sufficiency by helping them develop new activities and goals, whether as a volunteer or through leisure, personal growth, or advocacy activities, steps that accommodate their disability and provide them with a sense of meaning. The action-oriented problem-solving strategies characteristic of the fighting spirit are more consistently associated with positive outcomes than avoidance strategies, as long as there are aspects of the disease that are within direct control. Distraction and other emotion-focused strategies appear to be most useful for aspects of the illness that remain uncontrollable. The counselor can help clients develop multiple coping strategies and apply them differently to various situations arising during the progression of the disease. For example, as clients get sicker, they might be encouraged to focus less on searching for new treatment modalities and more on relaxation, dealing with family members, and completing unfinished business. Often, the counselor is the only one trusted to witness and validate the client's grieving and loss. Clients need to grieve the loss of the healthy person they used to be. They may need to grieve the loss of their dreams and aspirations. HIV is a disease of loss after loss, and it challenges good therapists to uncover sources of hope in the client, oneself, and others in the context of multiple loss. Counselors should support their clients with AIDS as they confront decisions about how they want to be cared for and where, how, and when they wish to die. Such decisions are complex, and the counselor or therapist may be the only person in the client's life who is willing to help weigh options and clarify desires. It is common for clients to put off decisions about wills, living wills, do not resuscitate orders, durable powers of attorney, guardianship of children, and funeral arrangements, because such decisions require clients to confront the emotional and practical realities of the end of life. Counselors may have to serve as mediators when the wishes of clients with AIDS conflict with the competing interests and expectations of families, friends, lovers, and healthcare providers. The role of mediator often expands to provider of support to significant others who are coping with feelings of impotence, grief, and anger stimulated by the client's impending death. Counselors need to be secure and clear about their own issues around death and loss in order to be helpful to others. It is important to remember that as death approaches, the object of hope may shift, but hope itself dies hard. Initially, there may be hopes for recovery or stabilization, but as HIV progresses, the perspective of the patients often shift, and they hope to live through this summer, until a child visits, or until they finish a project they have been working on. Later, hope may become invested in the activities of friends and family who will survive, or in a peaceful death that occurs in a manner consistent with the client's direction. If clients are religious, they may hope for eternal life and eventual reuniting with family. As the focus of hope shifts, the counselor can assist clients to redirect energy to thoughts, goals, and activities related to what matters most to them at the time. It's important to approach dying clients with an open mind and with respect. Generally, at the final stage of the disease, clients are more aware of their needs, strengths, and weaknesses than is the counselor. In fact, we may find ourselves becoming more passive, but yet very present in our approach as the roles of teacher and learner change at the end of the client's life. Experienced counselors sometimes refer to themselves as witnesses at this stage of the work. One more important point. Saying goodbye is hard. It tends to be avoided. An important question that counselors should repeatedly encourage their dying clients to consider is there anything that feels left unsaid or undone? It is critical that counselors ask the same question of themselves. If they do not, they are placed at greater risk for emotional blocking connected with unexpressed anticipatory grief. Thank you.
Thank you, Bob, for an extremely comprehensive and also very sensitive presentation. One of the issues that you talked about is the issue of depression, and it's a very complicated issue in HIV disease. I'm wondering if you could say a little bit more about it. How do we tell when somebody's depressed whether it's normal or not, whether it's HIV disease or whether it should be treated with psychotherapy or pharmacologic means?
Yeah, it's a good point. I think it needs to be discussed. We need to acknowledge the fact that it is difficult to do a differential diagnosis. And sometimes we may not be able to do that. We may need to call in other experts in psychiatric disorders and making these kinds of diagnoses. I think the points I'd like to emphasize are a couple. First of all, we shouldn't assume that some of the physical symptoms that go along with depression, like sleep disturbance, appetite disturbance, or lethargy, or loss of libido, we shouldn't make the assumption that they're necessarily related to HIV, that they really might be an indication of depression. It's hard to tell, okay? The other thing I think is important is that we don't assume that someone who is HIV infected or someone who has AIDS should necessarily be depressed in the clinical sense. It's normal for people to have down days, mood fluctuations, and some distress, but when someone is having persistent, chronic, depressed mood or anxiety and a lot of the symptoms that go along with it, then that's not normal. And a lot of the research shows that's not normal. So we should be very aggressive. I think of it just as we need to be aggressive about treating people with opportunistic infections. I feel the same way about something like a psychiatric disorder, that we should be very aggressive about getting people symptomatic relief. That there are treatments available for depression, and our studies are showing that even with people with severe immune suppression, that pharmacokinetic intervention sometimes is really appropriate, as well as counseling and more intensive psychotherapy. So let's not assume that depression goes hand in hand with HIV infection. When we see it, or we think we see it, if we can't make the differential diagnosis, let's refer maybe to a psychiatrist or someone who can make that differential, and let's actively treat it with both psychotherapy and, when appropriate, some kind of pharmacokinetic intervention, both for anxiety disorders and for depressive disorders.
And in point of fact, an easy differential may not be possible.
Yeah.
And it may be important just to try therapy to see what might happen.
Try therapy and see what happens, exactly.
Yeah.
Now, the issue gets complicated when thinking about persons who have abused substances who are trying to be clean and sober. And many of the people who are trying to be clean and sober really don't want to get involved with substances at all, and many of the programs encourage them not to get involved with substances. For those of you who are involved with counseling people with substance abuse, how do you deal with this issue of anxiety, depression, treatments for anxiety and depression for people who are trying to be clean and sober?
I think it's important to recognize that to the same extent that treatment intervention and approaches for HIV is changing as we learn more about the disease, so too is our philosophy and treatment approach for addicts is beginning to change. We have come from a period in which we used to say to drug addicts that it was okay to drink alcohol but not to do illegal drugs. Well, we clearly have moved a long ways from there. And we went to the other extreme where you were not to use any drugs for anything. You were just supposed to stay totally drug-free, and if you were in pain or anxiety or depression, you were just supposed to work it out through therapy. We now know that long-term use of drugs in itself may cause a number of complications, including anxiety and depression disorder, that perhaps can better be treated with drug intervention. So again, and also the issue of pain maintenance. And yes, there may be a lot of manipulation in order to get by the addict to get some drugs, but there has to be a reality check there, that if the person is in pain, if the person has disorders that can be treated with medications, then that person has a right to have access to those medications. So again, it takes a partnership efforts of the AIDS service providers as well as the drug treatment providers and sponsors and buddies and everybody working together to really get a handle on what's really happening with the addict and what's really happening with any client that has multiple diagnoses.
I really agree with you, Bob, about long-term chronic depression, but I'd like to differentiate that for a minute with a depression that comes from a change in status, a new opportunistic infection, CMV, whatever. And people invariably get depressed with a change in status. One of the things I do is try to normalize that and to tell people that they'd be crazy if they weren't depressed. It's depressing. The other is to reframe it and talk about it in terms of grief, that we are grieving for the thing we lost. Often those two interventions, reframing and giving permission to be depressed, enable people to spontaneously move out of depression. Again, if the depression lasts for more than a week or two, then I'm going to look at psychiatric consult, something else. But somehow those things seem to work incredibly well.
I agree. But it is important to emphasize your last point, that if it persists,
Absolutely.
I worry about the client, the counselor who feels like, oh, it's expected, you should be depressed, but that's usually more acute. And if it doesn't get relief, then we have to think about something else.
Absolutely.
Yeah.
It sounded to me like those two very same strategies applied to expressions of suicidal thoughts. That
Yes.
they're normal, that
Yes.
anyone with a life-threatening, potentially terminal illness is going to think that way. And reframing it as normal and and as expected, and helping people think about what that means is part of the process of learning that one has HIV and going from there. Right. Yeah. And it's safe to talk about those very scary thoughts. The other point that I was really struck by in your presentation was the issue of goals, and constantly resetting and rethinking goals as people progress through the various stages of HIV. I'm wondering if you could give us some examples of the kinds of goals that some of your clients have set as they've progressed through.
Well, I think like the examples I mentioned, I mean, the goals can shift over the course of the illness. And in later stage illness, you'll see people with shorter term goals, you know, like accomplishing something within the next month, or getting through, you know, a period of time, a season, or wanting to see someone again, or wanting to do something with a child, or wanting to leave something behind for their children. That becomes a goal that their energies and efforts get focused on. And I think having goals is so important. They're so key. When we first did our study of AIDS long-term survivors, one of the common factors among just about all of them was just having some kind of goal. And they spontaneously talked about the importance of doing that. And we also have to acknowledge the loss of some of the more longer-term goals, that it is an illness of loss. And we have to acknowledge people's grieving over loss, that they may have lost a sense of very long-term future. But they can, again, we can do reframing with our clients and refocus and reframe how they set goals and what is meaningful to them in their lives today. And I think the client has to decide what that is for them. We can't tell them what their goals should be. But we can help them reframe and shift, and they can become more short-term goals, but nevertheless still very meaningful. And I think that's what's important, that they still remain meaningful.
Bob, as I was listening to your presentation, I found myself thinking about how the family and the significant others of the individual, how their emotions and feelings often parallel, but often are not in sync with where the individual is, and how that can be very difficult for a client to really tolerate. Particularly, I've seen people who, in fact, have been really towards the end of their life and have made some decisions about ceasing drugs, etc., whereas the family or significant others have not accepted that, creating this kind of discordancy. I'm curious in terms of, you know, what role might a counselor really have to kind of work with a family or significant other in that area?
Well, that can really vary, I think. I mean, sometimes we can interact on an informal basis. I mean, I've had the experience of visiting a client in the hospital or at home, and family happens to be there. Maybe I've never met them before, and you end up in the kitchen or in the waiting room with, you know, mom or the lover or someone who is, example you're talking about, having difficulties with where the client is at. But I advocate for, when possible, to do more systematic family intervention. But you have to have, you know, the client that you're working with needs to give you permission to do that. The family needs to be willing to talk to you. But I think you're absolutely right in pointing that out, that often we can serve a role in terms of helping significant others cope with their feelings of loss, their feelings of guilt, their feelings of grief. Because often the client is moving much faster on those issues, sometimes than we are in terms of our countertransference, and certainly often more than the family is doing.
The issues of transference and countertransference are enormous. I mean, it seems to me that, you know, one important role that the counselor can play is being a person who is available to the client, who isn't invested as a family member would be or a lover would be in the choices that are made. And yet that's hard to maintain because we have our own relationship with the client as well. And it's hard to lose the client. And so it's hard to sort of maintain that objectivity and allow the client to make his or her own decisions.
Yes. It is hard, but I think it's a unique position that we find ourselves in, that we have to find, that's our challenge, is to maintain that, because we might be the only person the client can really open up on some of those emotional issues to, because we're not invested as a family member is. And so you're right, it's a fine line, but I think we have to maintain, whether you call it a psychological distance or something that we have to figure out for ourselves, that allow us to be something that the lover can't be, or the mother can't be, or whoever the significant other can't be. And we need to be that for our clients.
The point about denial is an interesting one. Denial in classic psychological theory is not good, and yet you state that it might be adaptive and helpful.
I think it is. I think it really can be. I think it's important to be able to, when living with HIV and AIDS, you need to be able to shift how prominent it is in your mind on any given day. I mean, a lot of people say, I think of it every day of my life. But the question is, how much do you think of it? Can you sort of shift it to the back and still go about your life? If you're physically healthy, you know, can you think about having a future? Can you think about a year from now, a couple of years from now? Not knowing. I mean, the uncertainty is a powerful thing because we don't know. But I think I use denial in an adaptive way when I say that you can be able to shift it and live with the attitude that there is some future. I don't call that denial in the classic sense where it's maladaptive. I think, as I said in my talk, that denial is maladaptive when it gets in the way of confronting the realities that are there in front of you. But in this vague sense of uncertainty, I think some sense of what some people would call denial is really adaptive because we don't know the length of future. And I think we have to live in this world with a sense that we have some sense of future.
And it becomes even more complicated working with addicts in which the issue of denial is confronted greatly. I mean, you will hear the term and service providers talking and other recovering addicts telling persons in treatment to get out of denial and yet on one hand that's very important as it relates to their recovery process for drugs and alcohol, and yet to get them to understand that there's also a coping mechanism, as a survival mechanism for dealing with HIV disease that can play a very positive role for them, and to make that distinction calls for a lot of training and sensitivity and a shift of thinking around how we talk about denial, particularly for that population.
Our next speaker, Judy Polachek, is a psychotherapist in private practice in Washington, D.C. For the past 10 years, she has worked with more than 150 people living with HIV infection and many of the people who have grieved for them, lovers, spouses, caregivers, and parents. Judy will talk about what she has learned about grief, how it manifests itself, how to help others work through it, and how to cope with it as a caregiver, especially when many people we know and love are dying. Judy?
Thanks, John. Today I want to share with you some of what I know about the symptoms of treatment of grief and what my clients have taught me about expanding my knowledge in order to work effectively with people grieving HIV-related deaths. People may find themselves offering direct services to PLAs for a variety of reasons. They may be drawn to AIDS work because of a political or personal bias. They may be social workers or psychologists in prison, hospitals, in or outpatient drug rehabilitation centers. They may work for ASOs. They may be nurses on infectious disease wards or cancer wards. They may be old-timers drawn to the struggle or newcomers to the HIV pandemic. They are probably people who are good at their work and not afraid of the challenge. They are people who are trained to help, to fix, to cure. And then they meet in growing numbers the people living with HIV infection. They meet people who are just like them, young people, people with families, mothers with young children, gay people, nice people, most of them anyway. And they work with them, and they fight for them, and they pray for them, and they watch them lose. They watch them lose their vision, their mobility, their jobs, their children. They watch them lose bladder and bowel control. They watch them lose their minds. They watch them lose their lives. And indeed, we have not been trained for this. We have not been trained to lose so many battles with so many people who are just like us. And so we feel helpless. What are we doing here anyway? We are overworked and overloaded, and we don't seem to be making much of a difference in the world. And nobody has told us about death. Nobody has told us about grief. Nobody has told us that we will grieve. Nobody has told us how to grieve or what to expect. So I want to begin by discussing grief. Ordinary, uncomplicated grief. What happens to a person when a loved one dies, and how this can become more complicated when we are dealing with an AIDS-related death. I will discuss disenfranchised grief, a condition common among professional caregivers whose loss is often not recognized or validated by colleagues, friends, or family. I want to talk about what happens when ordinary grief is complicated by serial losses, when all around us people have died, people are dying, people will die, the phenomenon of multiple loss. And finally, I want to discuss the potential effect of grief and multiple loss on professional caregivers. The strong possibility that we may begin to experience the symptoms of burnout or post-traumatic shock disorder, and how we can care for ourselves and each other, the caregivers. Dr. J. William Worden, in his seminal book, Grief Counseling and Grief Therapy, outlines 4 major tasks of bereavement. These are to accept the reality of the loss, to experience the pain of grief, to adjust to an environment in which the deceased is missing, and finally, to emotionally relocate the deceased and move on with life. Let's examine these tasks against the backdrop of the AIDS pandemic. Accepting the reality of the loss. What do you do when a client or patient dies? Ideally, we arrange to spend some time with colleagues, caseworkers, and family, talking about our sense of loss, reminiscing about the person who died, attending a memorial service, or creating a ritual of farewell. In practice, however, we may do little more than transfer the client's file to the case completed drawer, or assist in admission of a new patient to the deceased patient's bed. There is no time, we say, with some justification for grief. We're over funerals, we say. Or perhaps we feel that as professionals, we have no right to grieve, that it is in fact unprofessional to get involved. We need to create a feeling of closure, whether in a case conference seminar, in a support group for professionals, with a trusted colleague or friend. We need to spend some time mourning the loss. Incidentally, don't assume that we only grieve for greatly loved or admired clients or patients. Some of our greatest losses can be difficult or non-compliant patients. One of the rituals I have devised began in January of 1985, when, as I filled out my new address book in a daily planner, I realized that I was routinely deleting the names of clients who had died. It felt callous, as if they had never existed. And so since 1985, I have simply kept one address book, adding names as needed. And now, as I look up an address or a phone number, there is a dead person on every page. And as I read their names, I pause for a moment and just remember. The next stage is experiencing the pain of grief. This, of course, is the tough part. The hope is that we can find our way around rather than through the pain. And so we begin to put one toe in the water. We hear our own voice telling us not to give into it, not to be a baby. We have the societal voice telling us to buck up, be strong, keep busy, don't give into it. And the societal expectation that normal grief takes only months to get through, when in fact it takes 2 to 5 years. We deal with disenfranchised grief, the notion that the grief is not ours to have, that it belongs to the families and loved ones of the deceased. We hear the voices of our professors in graduate school telling us we shouldn't have gotten so involved in the first place. We hear the voices of our partners and our families telling us that this HIV work is ruining us, ruining our relationship. And yet, if we fail to experience this pain, if we fail to give ourselves permission to grieve, experts such as Colin Murray Parks tell us that, and I'm quoting here, anything that continually allows the person to avoid or suppress this pain can be expected to prolong the course of mourning. John Bowlby has said, sooner or later, some of those who avoid all conscious grieving break down, usually with some form of depression. The key then is this notion of giving ourselves permission to grieve, to listen to sad songs, to cry, to bay at the moon, and quite simply to wallow. The next stage is adjusting to an environment in which the deceased is missing. This task usually refers to a time when you become comfortable in a world in which you no longer define yourself as the deceased's lover, mother, child, whatever. A time when you stop identifying yourself with a former role. For caregivers, however, the task is at the same time more subtle and more complex. The final task is emotionally relocating the deceased and moving on with life. This final task means that you can acknowledge that although your loved one is well and truly gone, you will be able to go on, move forward, and find meaning and enjoyment in life. Those who fail to accomplish this task often remain stuck, unable or afraid to invest in new loves or new relationships because of the ever-present fear of new loss. This is a fear that I often hear expressed by people who work in AIDS service organizations or hospitals with high volumes of PLAs. Therese Rando, in her 1984 book, Grief, Death, and Dying, tells us that there are 5 tasks necessary to complete the process of mourning. These are the 5 R's, essentially. They're called recognizing the loss, reacting to the separation, recollecting and re-experiencing the deceased and the relationship, and relinquishing the old attachments, and finally readjusting to move adaptively into the new world without forgetting the old. As you can see, Rando's 5 R's dovetail nicely with Worden's 4. Earlier I mentioned the phenomenon of disenfranchised grief, the feeling that perhaps we don't deserve to grieve. Kenneth J. Doka, in his 1989 book Disenfranchised Grief, says, "Societies have sets of norms in effect, grieving rules that attempt to specify who, when, where, how long, and for whom one should grieve. Grief may be considered disenfranchised when the relationship is not recognized, the loss is not recognized, or the griever is not recognized. All of these criteria are met by AIDS caregivers. Monthly memorial services, bereavement groups for caregivers, mental health days, all serve to tell the caregiver that the institution supports and recognizes the grief that we all feel. Caregiver grief needs to be acknowledged as the rule, not the exception to the rule. Regular and ongoing attention to the emotional needs of the caregivers can do much to alleviate the onset of symptoms of burnout. I would like to be able to tell you that AIDS service organizations have a greater sensitivity to the needs of grieving caregivers than other institutions, but regretfully I can't. Understaffing, budget demands, and a need for services that grows faster than the resources available all mitigate against such institutional sensitivity. When more than one person dies within a short time span, or when more than one person dies in a single accident, like an automobile accident or a plane crash, the survivors are left to deal with what the experts call multiple loss. There is a body of literature dealing with the care and treatment of this phenomenon. But the literature assumes that the losses were in the past, that the event or events are over, finished, and done with. I think instead we are dealing with a new phenomenon, one that Martin and Dean call chronic loss. John Martin and Laura Dean studied chronic loss among gay men in New York and found, among other things, that men who suffered chronic loss experienced elevated levels of depression, helplessness, sadness, cognitive impairment, suicidal ideation, actual suicide attempts, inability to be comforted by others, numbing, panic attacks, complaints and problems falling asleep and staying asleep, traumatic stress response, preoccupation with their bodies for signs of HIV, and frequency of occurrence of fears of developing HIV. Interestingly, they did not find a marked increase in alcohol use, but reported increased use of recreational drugs. In their research, which was conducted in 1985, they noted that they expected a diminution in these symptoms in the second 5 years of the pandemic due to the availability of the HIV antibody test and to the acceptance of safer sex practices. My personal observation in 1993 is that these symptoms have not notably diminished in number or severity. From this I conclude that believing oneself to be at risk for HIV or being HIV positive is not the primary stressor, although it certainly is a stressor. I believe that the ongoing exposure to chronic loss with concomitant feelings of helplessness and hopelessness leads to symptoms of what we call burnout or post-traumatic stress disorder. I believe that the discontinuity between what we feel and what we tell ourselves we feel is one of the primary causes of burnout. I cannot stress enough the importance of giving ourselves permission to grieve. It has become fashionable to refer to HIV caregiver burnout as PTSD. Sandra Jacoby Klein quite correctly points out that for AIDS caregivers there is no post, that the trauma is persistent and ongoing. So there isn't even a good name for what we've got. Ongoing trauma syndrome? Traumatic stress disorder? My husband tells me that the first step in dealing with something is being able to name it. That we need to develop a cognitive framework in order to understand what is happening to us. I am really struck by the parallel between the inability even to name or categorize HIV caregivers' stress or trauma and how it mirrors the nature of the pandemic. Once again, the book hasn't been written. We don't know the answers. We barely know the questions. The ambiguity of the caregiver's condition seems to reflect the ambiguity of our client's condition. I have been an HIV caregiver since 1983. I've lost hundreds of clients. I've lost dozens of friends. And I began to wonder why I wasn't burned out or stressed out or whatever we decide to call it. And I realized that I had three things going for me. One, I had been educated about bereavement. I understood the nature of grief. I had a cognitive framework for the emotions I was experiencing. Two, I was able to give myself permission to grieve. I knew the importance of not stuffing my feelings. And three, I worked in an environment, a counseling agency, in which I had institutional and collegial support for my grief. I was encouraged to talk about it, to share with others. If you take nothing else away from this talk, I'd like you to remember these three things, because I think these three things are the key to long-term survival for HIV caregivers. One, learn about grief through reading, through an agency-sponsored in-service, a workshop. Learn about the nature of grief. Two, attend a caregiver's bereavement support group. All of the literature I've read supports that this is the single most important factor in avoiding stress and burnout. Perhaps such a group can be initiated in your agency, or if it is a small agency in a consortium of similar agencies, lobby for it. Three, give yourself permission to grieve. Remember that the dichotomy between what you feel and what you tell yourself you should feel is a major contributing factor in stress and burnout. Grief is often the elephant in the living room. Learning about it, talking about it, and allowing yourself to feel it can reduce what is now huge and unmanageable to something that is still huge, but finally manageable. Thank you.
Thank you very much, Judy. Very, very nice presentation on a difficult topic that we all have to deal with and cope with, and it was very helpful.
Thank you.
You must be familiar with Kubler-Ross's theory of grieving and stages of grieving. Do you use it in your own practice? Do you find it applicable?
That's the most wonderful question, because it is frequently the question asked most of me, and it is the most well-known theory about death and grief probably in the world, and the most commonly applied. Yes, of course it's helpful, but that's exactly what it is helpful. Kubler-Ross herself, sometime after she wrote the book on death and dying, said that, wait a minute, folks, these stages aren't serial. And everyone seems to assume from reading the book that you start with whatever it is, denial. I always get them mixed up. Denial, depression, and you move on serially. the danger in that for people, because of course we don't. Some people are depressed periodically, they're in denial periodically, they're angry sometimes and not sometimes, or they stick with one mode that happens to be their particular favorite. The danger of that kind of serial stage theory is that, one, we keep trying to hustle somebody onto the next stage, which gives us as caregivers the luxury of not having to deal with what's on our plate. We can decide it's simply a stage. And two, it keeps us distanced from the client. It is the ultimate disrespect to the client to treat what he or she is going through as a stage rather than a feeling.
Well, Judy, I had a question for you. You know, when I first got into this, into working with HIV and clients, people were telling me, all different sorts of people, well, you can't stay in this field very long because, you know, the grief is too much. You're going to burn out. People even quoted, well, you can only do this kind of work a year, but you could do this kind of work 2 years or 3 years. What's your opinion on how long we can do this work and in terms of the grief, and how much can we do it?
My opinion is we can do it as long as we feel good about doing it, as long as it makes us happy. If you can wake up most mornings feeling good about going to work, I think we begin to develop some safety mechanisms for ourselves. I make much more liberal use of an answering machine than I used to. I used to feel 10 years ago that if the phone rang in the middle of the night, by God, I was going to answer it. I don't do that anymore, unless I know that somebody's dying. So I think that as long as it makes us feel good, as long as we feel effective, as long as we do things to take care of ourselves forever.
I think you bring up an important point, the issue of boundaries and limits. And I think, at least for me, I know, and a lot of other colleagues of mine have recognized the need to know what your limitations and boundaries are, and to sort of feel okay about having them. I mean, I think we probably choose different boundaries, like using an answering machine, or like taking weekends off, or whatever it is for you. I think we have to, you know, say to each other, it's okay to do that. And, you know, you do it this way, I do it that way, but we need to do it. We need to take care of ourselves.
One of the most difficult issues, I think, in grieving and bereavement, and I think it really relates here, something we don't talk about very much, and that is clients or patients about whom we have ambivalent feelings. I mean, the ones we like are the ones we really miss and grieve. Do you have any particular strategies for dealing with clients or patients about whom you might have ambivalent feelings?
I don't think it's any different in HIV work than any other work. But one of the things I try to do is join them, is just see how close I can get to joining them in what's going on, because it sometimes gives me a new perspective. And that's, I don't know if that makes any sense. But joining the client where the client is sometimes really helps to remove the ambivalence. Sometimes I think it's real important to relieve yourself of that client. I think there's some clients with whom we can't work. My Jewish grandfather, who was in the garment business, used to say, for every buyer there's a piece merchandise. And the client that may strike a discordant note in me may be my colleague's favorite client in the whole world. I mean, I think if something really bugs you, you need to get out of it, because you're not doing the client any good.
My question is, how does one know when one has completed the grief process of a loved one or a client or someone that you've been with close? I heard you talk about grief being 2 to 5 years, but culturally, I am sort of taught you do the funeral and it's over with. You move on with your life. So hearing that grieving takes place 2 to 5 years, I'm not sure I know when it has ended, because I assume it ended, you know, after the funeral. And then the other second part to that is it grief always a feeling of sorrow or sadness? Can it be a feeling of relief and I can get on with my life now?
I think there are different griefs for different people, and it often has nothing to do with how close we were to them. It may partly have something to do with whether there was unfinished business or no unfinished business between you and that person. Some deaths are simply, when they happen, a relief is not maybe the right word, but neutral, value neutral. It's been a good relationship. You have nothing to reproach yourself with. There was no unfinished business between you. You did the best you could, and somehow that's fine, that's okay. I agree with you that seemingly grief is culture laden and that black folks are taught that it's over after the funeral. But my guess, it isn't my guess, I know perfectly well, that if you ask any mother whose 12-year-old baby has been shot on the streets of Washington, if 1 or 2 years later she isn't grieving, my guess is she's grieving. It just varies from person to person. I think you really know if you're preoccupied with that person, if you are filled with yearning behavior, if you think about them often and persistently, you're still grieving. If after a week or two you can let go of that, then you can assume you've let go of that.
In my experience, it reemerges often in unexpected ways.
Yeah.
You know, you go through a period and then maybe a year later, sometimes it's the anniversary date, sometimes it's a couple of years later, or it's another death triggering a reaction to a previous death. And sometimes I'm always surprised at how unexpected it is. Sometimes it just, I'll be riding the subway and all of a sudden I'll read something in the paper, it will just trigger.
And that happens for people who, for partners and spouses and parents and children, 2, 5, 10 years, 20 years after, where suddenly something will trigger an emotion or a moment, and the grief will be as strong as the day the person died.
Yeah. I think that's why your phone book example, and you know, for me, I have a picture of a friend who died several years ago, and it happens to be in my desk drawer, and I've never, every time I open up my left drawer of my desk, it kind of pops out, and he's kind of there, and I just acknowledge it, and have never thought about moving it. It's just kind of in this pile. And it's just, for me, a helpful way to be reminded, yet I also feel like I've moved on. And you know, that process has been in motion. For me, Judy, you mentioned caregiver grief is the rule, and I guess it's a difficult question, but what kind of advice can we give to HIV counselors or even people who are doing HIV-related work these days to try to advocate for agencies to, in fact, recognize grief on that level? I think that's just a real challenge. Many of us are from AIDS service organization backgrounds or currently working with that, and I agree, it's rarely the norm. Any thoughts on that, on how do we push that agenda forward?
I think we need to start at the top rather than the bottom, but having people lobby for putting things in suggestion boxes. I think if we look, for instance, at the bereavement policies of ASOs, 3 days off when your partner dies, most corporate America gives you more than 3 days off when your partner dies. I mean, from that on, it tells us as workers what people think of our grief, that it's not worth it. And the truth of the matter is, and maybe the place to start, is that it is cost effective to give employees adequate grief work. People don't work well when they're grieving.